Good afternoon. My name is Joe Schwab, and I'll be speaking about machine learning in spine. Is it here or is it hype? When we talk about hype, it's useful to look at the Gartner hype cycle. I think most of us have looked at this, and I think it's useful to look at the curve and try to understand it. There initially is a technology trigger. Machine learning has been around for a long time, but I think the trigger for the utilization of machine learning more recently has been because of the advent of the GPU and cloud computing. That sort of democratized the use of machine learning. And that led to a big peak in inflated expectations. All of us have witnessed that. That's machine learning and AI is really everywhere these days. Unfortunately, that does then fall into the trough of disillusionment, and I think we're sort of heading into that trough to varying degrees now. After that, there's this thing called the slope of enlightenment, and that's where more proven technologies or durable parts of machine learning or the hype tend to last before you get into a new industry or sort of a stable industry, the plateau of productivity. With regard to artificial intelligence, there's lots of different areas, obviously, but the areas that I'm going to be talking about today are machine learning, natural language processing, and a little bit about computer vision. And I think we're sort of just passing the peak in terms of expectations, and I do believe we are heading towards the trough of disillusionment for some things. But again, there are each one of these attributes has their own curve, and they're on different stages of the curve. So what about machine learning? Well, machine learning is useful for many things, but one of the things that it's particularly useful for in medicine is for decision support. And so when we talk about decision support, we're often talking about predictive models. Predictive models have been around for a long time. At least 100 years ago, they were using nomograms, and nomograms are quite useful for pad and pencil. But they have sort of given way towards machine learning and other statistical analysis with the advent of the EHR. And a question we have to ask ourselves, or should ask ourselves, are all predictive models created equally? And how do we know if we can trust a predictive model? There really are a lot of predictive models out there. Do you know which ones you can use and which ones can you not use? And I think one of the things to understand is that there are criteria for predictive models, and that's called tripod. Tripod was developed because of this problem with the advent of many different predictive models. Which ones are worth using, which ones are safe to use, because they are being used in clinical practice now. We decided to look at this specifically for machine learning in orthopedics and in spine, and we found that there were 59 machine learning based predictive models in orthopedics and spine, and unfortunately most of them don't subscribe to the tripod methodology. And to be fair, the tripod methodology was not designed specifically for machine learning, and so there are a couple of the nuances in tripod that don't really fit for machine learning, but the vast majority of them do. And tripod is coming up with a specific machine learning guidelines subsequently. But suffice to say, most of the machine learning algorithms that are currently in publication do not subscribe to tripod. One of the important aspects of tripod or any predictive model that makes sense, you really have to validate your models externally. If you don't externally validate your models, it doesn't mean they're not useful, but you do have to wonder, they really do need to be validated. And unfortunately, the majority of the models that currently exist have not been validated. Only 20 of the models in spine have been used, and only 2 of them have been externally validated. So 2 of the spine models have been externally validated. So let me go over one of our models that we predict that's particularly apropos for cervical spine, the anterior cervical discectomy and fusion. We looked at 2,700 patients. We're trying to predict whether or not these patients are going to be on opiates long-term after surgery. And we found that about 10% of our patients were indeed on opiates long-term. And we define long-term as patients who received a continuous prescription for opiates after surgery, at least 90 to 180 days after surgery. That met our criteria, and again, 10% of our patients met that criteria. So whenever you're looking at a predictive model, you need to have a C statistic, right? That's sort of an entry-level statistic. If you have a low C statistic, you shouldn't use the model. If you have a high C statistic, it doesn't mean the model works. It means that it might work, but you have to do further investigation. Another aspect of predictive models, most of us are familiar with weighted parameters. So when you look at a linear model, all of us have seen that in the past, where you can see which parameter was weighted the most, and that was helpful in terms of understanding the model. And we should require the same thing in machine learning algorithms. Now, if you have an unsupervised model, it becomes a little more difficult. But most models, when we're talking about developing predictive models using an EHR, you know what the parameters are, and you should be able to provide the weights. So in this case, in our model, the weights are, as you see on the right. If a patient was not on opiates before surgery, that was the most predictive of whether or not they'd be on opiates after surgery. The second most predictive model or paradigm was the patients who were on opiates for 180 days prior to surgery, followed by the use of antidepressants, followed by tobacco, and being on Medicaid. All of these factors were predictive, and I think it's important if you're going to use a model to try and understand what parameters were used to develop that model. Very importantly, you should have some means of assessing the accuracy of your prediction. It seems pretty obvious. If you're going to use a predictive model, you want to know, was it accurate or not? And one way to assess that is with a calibration curve. So if you look at this curve on the left, the x-axis represents a range of predictions from 0 to 100%. And if you predict that someone has a 20% chance of having whatever you're trying to predict, the observed proportion should also be about 20%. And if you're predicting 80%, the observed proportion should be about 80%. If it's perfectly calibrated, you'll have a slope of 1. And you can see our model here, which is the dotted line, is not perfect, but it's pretty good. The other thing you look at here is you want to look and see where your curve crosses the y-intercept. If it crosses in a negative zone below the x-axis, then what that means is that your model is over predicting systematically. And conversely, if your curve crosses the y-intercept above the x-axis, or it's positive, that turns out that you're underestimating systematically. And so calibration curves are very, very important and very useful in terms of assessing whether or not a model is accurate or not. And then decision curves on the right. Decision curves are relatively new. They've been around for about 15 years or so, coming from Andrew Vickers of Sloan Kettering. And what you're looking at here is you're trying to designate a threshold value. So, for instance, in our case, we're trying to predict opiate use. And we might say that, well, you know, if I could predict that my patient has a 10 to 40% chance of being on opiates, then I might consider at that point some sort of mitigation strategy. And if they're below 10%, maybe I wouldn't have a mitigation strategy. This is just a threshold value that you have to think about. And we're comparing our model to a strategy of, well, I'm not going to mitigate anyone, versus I'm going to mitigate everyone. Every one of my patients is going to go to this mitigation effort, which is probably not feasible. And in this case in particular, we also compared our model to whether or not somebody was on a prescription opiates prior to surgery. Because you could argue, all I do is if they're on opiates, I send them to this mitigation pathway. I don't need your model. So our model we compared our model to that method as well. And what we found was over that risk threshold, our model was superior. Our model did have net benefit over all three of those. And this is just one way of assessing whether or not your model is really useful in clinical practice. And so you know it's accurate, you know it has a high C statistic, but is it useful for a risk threshold that's meaningful to you? And that's why decision curve analysis is important. The problem with this model is there's no validation. We've not validated this model externally. And so can you use this? Well, I certainly can use this. I'm comfortable using this in my hospital system. But should I say everybody else should use it? Well, they should understand it hasn't been validated. So it might be useful, but I can't say that definitively. So what about NLP? So natural language processing is sort of in the scheme of AI and also machine learning. Is it useful or is it all hype? Well, we actually designed a natural language processing algorithm to detect durotomy. This is in spine, but it's in lumbar spine. And in this case, what we did was we compared our natural language processing algorithm to CPT coding or ICD-10 coding. And we used microdiscectomy. We used what's called an extreme gradient boosting algorithm, and we had 1,000 cases. And what we found was that actually we had about a 9% rate of durotomies detected with our natural language processing algorithm. And what we found was that the CPT code or ICD-10 code really underperformed. If you just use CPT and ICD-10, you're missing a lot of durotomies. The reported rate in the literature is about 3%, and that's because most of those rates are based on CPT or ICD-10 coding. That misses it because people don't code it. If you have a bleb in surgery, some people don't code that. Well, you could argue they shouldn't code that, but the point is there was a durotomy there, and whether it's clinically useful is a different debate. But the idea here is NLP can be useful. I think it's more useful to use NLP, particularly if you're looking for subtle things like complications when you're comparing it to CPT and ICD-10 codes. And this was actually validated. Dan Schuba's group validated this model, and it worked well. Okay, so if you want to use these algorithms, you can go to our website, sorg-ai.com, and other people have different websites and different ways of using predictive models. You go to the website, and this is the forward-facing algorithm. You put in your data, and you get a probability that would come out, and that we have lots of different predictive models on our system. And that's fine. But the problem is it's really not that fine, right? You have to stop what you're doing, and you've got to take your data out and put it on a website. There are lots of actually impediments to using machine learning based decision support, particularly predictive models. One of them is there's too few algorithms. We showed that there aren't that many algorithms, and the quality of the algorithms is suspect, and that's because they really haven't. We don't know if they work or not because they have not followed the tripod guidelines. Some people find there are medical legal concerns using these algorithms. I'm not sure about that, but certainly some people feel that it is. But the number one biggest impediment to the use of machine learning is workflow. We don't have a good workflow for integrating these into practice just yet. And so we're trying to solve that. Lots of people are trying to solve that, but we have a collaboration where we're trying to utilize applications called Smart on Fire. And what these applications do, they allow you to pull from your EHR, not just Epic, we happen to use Epic, but not just Epic, but any EHR. You pull data from your EHR, you run your algorithm in your app, and then the app is then seemingly embedded in the EHR, though it's really parallel to the EHR. But the point is that is a way of integrating these models into practice, which is not done easily just yet. This process is much more complex than I realized and much more costly than I realized. So first you have to select the algorithms, and we've talked about that. And then you have to automate the collection of the real-time data. And again, you have to decide which data that is. There's lots of different types of data that you might use in your algorithms, and how do you pull that data? How easy is it to pull the data? It really is variable. And then you have to develop some sort of visualization interface. How are you going to interact with the physician to get them to use the application? There's lots of applications in the EHR that people never use because they don't see it. It doesn't fit into their workflow. And then you have to develop pilot studies. You get this integrated and you run some pilots and see if it works. If that does work, you can deploy it. You deploy it in multiple institutions and see how that goes. Once that's done, you can do a prospective study, not necessarily a trial, to see how it impacts practice. So it's a fairly involved process. It's actually a very expensive process, lots of software engineering that goes on. So finally, computer vision. So I'm not going to spend a ton of time on computer vision. It's actually a huge area. Our own Dan Schuba has been involved in some of this as well. If you see on the left, this is a augmented reality use of computer vision, which will certainly be competing with some of the other current products that are in the market. And then you have computer vision on the right, where you are diagnosing fractures, which has a different level of clearance. They have to get FDA approved to use that as a diagnostic method. In conclusion, machine learning is hyped, but it is the future. At one point, we'll not discuss machine learning because it'll be so common that it'll be redundant to mention it by name. I think that machine learning skills will be ubiquitous in high school mathematics and computer science curriculum. It incorporates several of the skills that many of us learned in high school, such as calculus and linear algebra, combined with coding, which I didn't learn in high school. The hype will go away, but machine learning is here to stay. Thank you very much.